Welcome to the Explainer. Today, we're diving into a really challenging diagnosis, infective endocarditis. It's this incredibly serious infection that can literally hide deep inside the heart. And understanding it, well, it's absolutely critical because getting the diagnosis right and getting it early can mean the difference between life and death.
So, picture this. A patient walks in with a fever, chills, and you listen to their heart and hear a brand new murmur. What's the link between these things? Well, these classic signs are shouting that there might be a life-threatening puzzle unfolding right inside the heart, a puzzle we absolutely have to solve.
Okay, so to solve this thing, we need a plan, right? Here's our roadmap for today. We're going to start with what infective endocarditis actually is, then look at how it develops, how to spot the clues, and, crucially, how to confirm the diagnosis. After that, we'll talk treatment, and finally, prevention and the big takeaways. Let's get into it. All right, first up, the target. Let's define exactly what we're dealing with. So, what is infective endocarditis? So, at its very core, infective endocarditis, or IE, is an infection of the endocardium. And what's that? It's just the inner lining of the heart's chambers and, most importantly, the heart valves. But it's not just about the natural heart structures. This infection can also set up shop on things like pacemakers or other implanted devices. Now, it's really important to know that IE isn't just one single thing. We actually classify it in a few different ways. Is it on a native valve or a prosthetic one? Did it come on super fast, like in a few days, that's acute? Or did it creep up slowly over weeks or months, which we call subacute? And finally, where did the person get it? In the community or in a healthcare setting? This stuff matters a lot because it helps us make our first best guess on treatment, even before we have all the answers. So who's at risk for this? Well, some people are way more vulnerable. Think about it. Folks with prosthetic valves, or who've had IE before, or just have some underlying heart issue. Then you have patient factors, like being older or having a weakened immune system. And then there are the exposures, things that give bacteria a direct route into the bloodstream. We're talking about IV drug use, having long-term catheters, or even just poor dental hygiene. All these things basically roll out a welcome mat for bacteria, inviting them to come in and set up a home right in the heart. Okay, so how does this actually happen? Let's talk about the break-in. How does a bug from somewhere else in the body manage to cause such a huge problem in the heart? Let's unpack this step-by-step process. It's really like a four-step heist. First, you get some injury to the heart's inner lining, the endothelium, maybe from some turbulent blood flow. Step 2, the body tries to patch it up, forming a little sterile clot made of platelets and fibrin. Think of this as the perfect, sticky landing pad. Then, step 3, bacteria get into the bloodstream for a short time. We call this transient bacteremia. This could happen from something as simple as a dental cleaning. And finally, step 4, those passing bacteria see that sticky clot, they latch on, and they start to multiply. They build a fortress, an infected mass we call a vegetation. And that vegetation, that's the headquarters for all the trouble that's about to come. So who are the culprits behind this break-in? Well, we have a list of usual suspects. Staphylococcus aureus is a huge one, often the most common bad guy. Then you've got your streptococci and enterococci, and sometimes you run into this weird group called hayseck organisms, or even fungi, which are less common but can be really, really serious. The key is, some of these bugs are fastidious, meaning they're picky and super hard to grow in the lab, which can make our job a lot tougher. All right, this infection doesn't just stay in the heart. It leaves a trail of clues all over the body. So let's put on our detective hats and talk about spotting the signs. This is so cool because the classic signs of IE fall into two main buckets. On one hand, you have vascular phenomena. This is when little pieces of that infected vegetation, those fortresses, break off and travel through the bloodstream. They're like little infected missiles, causing things like Janeway lesions or splinter hemorrhages. Then, on the other hand, you have immunologic phenomena. This is all about the body's own immune system freaking out because of this long-term infection, leading to things like Osler's nodes and Roth spots. It's the infection itself and the body's reaction to it, leaving clues for us to find. Okay, finding clues and having a suspicion is one thing, but now we need the proof. How do we go from I think it's E to I know it's E? Let's get into it. The initial workup is actually pretty straightforward. Just remember this simple 3-step mantra. Suspect it, culture it, image it. First, your clinical suspicion has to be there. The fever, the murmur, the risk factors. Second, and this is the big one, get blood cultures to find the bug. And third, get an echo to actually see what's going on in the heart. Suspect, culture, image. That's your starting point. Let's talk about blood cultures because this is the absolute non-negotiable cornerstone of the diagnosis. The cardinal rule is you have to get at least 3 sets of cultures before you even think about starting antibiotics. Why? Because if you give antibiotics first, you can suppress the bacteria and the cultures will come back negative. You'll essentially be hiding the culprit. This leads to something called blood culture negative endocarditis. And trust me, that makes everything a million times harder to figure out. Okay, so after cultures, we need to see the heart. That's where echocardiography comes in. You've got 2 main types. First is the transthoracic echo, the TTE. This is the quick, non-invasive one you do on the chest wall. It's like peeking through a window of a house from the outside. You can get a decent idea of what's going on. But then you have the transesophageal echo, or TEE. For this one, a probe goes down the esophagus, right behind the heart. This is like getting a key and walking inside the house. The view is incredibly clear and detailed. It's way more sensitive, and it's an absolute must if you're dealing with a prosthetic valve or you're worried about complications.
So how do we put all these pieces together? The cultures, the echo, the physical signs? Well, we use a standardized scoring system, the gold standard, the Duke criteria, which were just updated in 2023. Think of it like a checklist. You have your major criteria. These are the heavy hitters, the smoking guns. We're talking definitive proof, like positive blood cultures or seeing that vegetation on an echo. Then you have the minor criteria. These are all the supporting clues, the fever, the risk factors, those vascular and immunologic signs we talked about.
And this is where it all comes together. We're not just guessing, we're doing some diagnostic math. To make a definite diagnosis of IE, you need to hit one of 3 combinations. You either need 2 major criteria, boom, you're done, or you can have 1 major criterion plus 3 of those minor ones, or if you don't have a major one, you can get there with 5 minor criteria. Hit any one of those thresholds and you can confidently make the call. Okay, we've got our diagnosis. Now it's time for the response. And this isn't a one-person job. Management requires a swift, 2-pronged attack, and it always involves a dedicated endocarditis team. The first move is always to start IV antibiotics, and we do it empirically. That's a fancy word for we're starting with our best educated guess. Based on whether it's a native or prosthetic valve or how the patient looks, we choose a combination of strong antibiotics to cover all the likely bad guys. This is just our opening salvo. Once those blood cultures come back and tell us exactly what we're fighting, we can tailor the treatment and switch to more targeted weapons. But here's the thing. Antibiotics aren't always enough to win this fight. Sometimes you have to call in the surgeons. When does that happen? Well, if the infection has physically destroyed the valve and the heart is starting to fail, antibiotics can't fix that structural damage. Or if you have a huge vegetation that's at high risk of breaking off and causing a stroke. Or maybe the infection just isn't clearing up with meds, or it's caused a complication like an abscess. In these cases, surgery to clean out the infection and repair or replace the valve becomes absolutely life-saving. All right, we've talked about finding it and treating it. Let's finish up with the defense. How do we prevent this from happening in the first place, and what are the absolute must-remember points from all this?
So prevention is a big topic, especially when it comes to dental procedures. Now, we used to give preventative antibiotics to a lot of people, but the guidelines have really changed. Today, it's only recommended for a very small group of the absolute highest risk patients. We're talking about people with prosthetic heart valves, anyone who's had IE before, some specific congenital heart defects, and certain heart transplant patients. For these folks, a single dose of antibiotics before major dental work can be a powerful defense.
Okay, let's wrap this up with the 4 things you absolutely have to remember. Number 1, always have IE on your radar for a patient with a fever and a new heart murmur, especially if they have risk factors. Number 2, your workup stands on 2 pillars, blood cultures, which you get before antibiotics, and an echo. Number 3, use the Duke criteria. It's your systematic guide to get you to the right diagnosis. And finally, number 4, remember that treatment is a marathon, not a sprint. It means long courses of IV antibiotics and a whole team of experts working together. So I want to leave you with one final critical question to cement this in your mind. In a patient where you're even thinking about IE, what is the one thing you absolutely must do before starting those antibiotics? The answer to that question is what makes this whole diagnostic journey possible. Thanks for joining me for this explainer.